Welcome everybody to today's American Thoracic Society Thoracic Oncology Assembly live webinar. Thank you all for joining today. So welcome to part two of our series highlighting the ATS 2024 Thoracic Oncology Assembly abstract winner presentations. I'm Roger Kim, the chair of the ATS TOA Early Career Professionals Working Group. And I'm also assistant professor of medicine at University of Pennsylvania. And I'm joined today by my co-moderator and co-chair of the Early Career Professionals Working Group, Tejaswi Nadig, who is an assistant professor of medicine at the Medical University of South Carolina. Like I said, we'll be moderating today's discussion. And before we get started, just wanted to remind everyone that this is a live event that will be recorded and uploaded to our assembly website afterward. If you have any questions throughout the webinar, please do place them in the chat, and we'll try to address as many of them as we can, after each presentation. And as a reminder, the views expressed during this webinar are those of the speakers alone and not necessarily endorsed by the ATS. With that being said, I'm very excited to introduce our ATS 2024 Thoracic Oncology Assembly Award winners who will be sharing their work today. First off, we'll have Jeremy Mudd from Mount Sinai presenting his work, followed by Marie Karam of Indiana University. And then last but not least, we'll have Eman Metwally from the University of North Carolina. Each award winner will have about 12 minutes to present their work, and then we'll follow this with about 5 minutes of questions and discussion before moving on to the next speaker. So without any further ado, Jeremy, if you don't mind sharing your screen and getting us started off.
Certainly. One moment. Thank you, Roger. You all see my screen?
Looks great.
All right. Well, good afternoon, everyone. I want to thank Roger and Tejas for inviting me today and for moderating this very exciting webinar. To my co-presenters. So my name is Jeremy Mudd. I am a recent graduate of the Pulmonary Critical Care Fellowship at Mount Sinai, doing a postdoctoral fellowship research year. And my project that I'll be discussing today is entitled Longitudinal Quality of Life Following Sublobar Resection and Stereotactic Body Radiation Therapy for Early Stage Non-Small Cell Lung Cancer. I have no conflicts of interest to disclose at this time. So this will be a review for a lot of folks on this call, but the gold standard for treatment of early stage non-small cell lung cancer historically has been lobectomy. However, for older patients considered to be at higher operative risk, those with significant comorbid medical conditions, frailty, poor preoperative lung function, they'd previously been eligible only for sublobar resection or conventional radiotherapy. And just to review, sublobar resection has a few subtypes. We have both wedge resection, which is the removal of a small area of tissue around the tumor, as opposed to segmentectomy, which is the removal of a larger anatomic segment with more tissue removed. Then, in about the last decade or so, has emerged this new technology called stereotactic body radiation therapy, or SBRT, as an alternative therapy for patients with early stage non-small cell lung cancer considered to be at high risk for lobectomy. This is typically reserved for patients with smaller tumor size, less than 5 centimeters, without any nodal disease involvement or N0 disease. And it involves delivery of highly concentrated radiation beams with confirmation to the tumor morphology based on pre-procedural MRI and other scans. It typically involves 5 or fewer sessions, which is logistically a lot less taxing on patients undergoing this than conventional radiotherapy was, which could involve in excess of 20 sessions at times. So the literature that we do have, which is mostly retrospective studies, shows similar survival outcomes between SBRT and sublobar resection. We have this kind of highlighted here over on the right, one of the studies that I mentioned. However, there's very few phase 3 trials or randomized controlled trials at all that exist comparing the efficacy of these two treatment modalities. That's largely due to difficulty accruing participants, most notably in like the Roselle trial a few years back, and a few other attempts that have had to close because of difficulty getting enough patients. However, what we do know is that SBRT has a limited adverse effect profile and very favorable post-procedural quality of life when compared to surgery from the many other retrospective studies that we currently have. But while prior studies have measured quality of life after surgery, mostly in the form of lobectomy, or looking at patients receiving SBRT alone, there are very few, or actually none, that we were able to find that directly compared patient quality of life outcomes in sublobar resection compared to SBRT. So none directly comparing these two cohorts. And that's something we wanted to investigate a little further. So our group had the question of, in patients with non-small cell lung cancer with tumor size less than 5 centimeters in size, how do SBRT and sublobar resection compare in their effect on quality of life? With the hypothesis being that SBRT would be associated with a better quality of life than sublobar resection up to 12 months post-treatment, based on some of the other studies that we had seen. So to answer this question, we designed a prospective observational cohort study in multiple sites across the US, including our Mount Sinai Hospital in New York, Brigham and Women's Hospital in Massachusetts, Oregon Health and Science in Oregon, National Jewish in Colorado, and Wake Forest University in North Carolina. The inclusion criteria involved patients with stage 1 to 2A non-small cell lung cancer with tumor size less than 5 centimeters, who were considered by their provider, any treating provider, for SBRT or sublobar resection. And these patients were, by definition, considered to be high risk for lobectomy. They had to be English or Spanish speaking for the trial. And our exclusion criteria involved recent thoracic radiation or recent diagnosis in the past 5 years of another malignancy that wasn't a non-melanoma skin cancer, or severe cognitive impairment or dementia. So we started by doing extensive baseline surveys of both the patients and providers involved in treating the patients throughout our cohort. And this started off with our baseline surveys and then did interval surveys at intervals between 7 days and 12 months after treatment. And the treating provider would determine, based on their own assessment, whether the patient should get SBRT or sublobar resection. Our baseline surveys included extensive sociodemographics of the patients, extensive review of their comorbid medical conditions and lung function. We also looked at cancer details such as pathology, staging that was done prior to diagnosis, and any procedures done prior to diagnosis. We looked pretty extensively as well at their baseline functional status using the PROMIS and ECOG scores, and also looking at their quality of life at baseline. And the metrics that we used for our quality of life assays were the short form survey 8, mental and physical. These are adaptations of the SF-36, which is a very well validated quality of life survey on a Likert scale. It's used extensively in the literature. We also use the functional assessment of lung cancer therapy, or FACT-L, which is even better validated in our particular lung cancer cohort that we were looking at, but also on a Likert scale. And because there was some degree of uneven distribution in the treatments that the patients were distributed to, we use propensity scores to try to adjust for any confounders in the data there. Sorry. So this is just a sample of the extensive baseline demographics that we have on all of our patients. And as you can see here, just a few select demographics to highlight. In particular, both groups were quite old, with the SBRT group being about 5 years older on average than the sublobar resection group. Both groups were predominantly white, and this is from 5 different medical centers across the US. And the majority of patients were from a lower socioeconomic status, predominantly with an income less than $50,000 a year, particular among the SBRT cohort. And here you can see that the FEV1% predicted was significantly lower in the SPRT group by about 20% than the sublobar resection group, which makes sense given that this was a surgical cohort relative to the SPRT group, but something to note for sure. And then in both groups, there was lower baseline functional status than the average population, with about 20% of the SPRT cohort unable to carry out work or worse at baseline. And the tumor sizes were close to about 1 centimeter in both groups. So we then used our quality of life metrics that I mentioned, the SF8 physical, mental, and FACT-L, and we used our propensity score methods to generate adjusted quality of life changes from baseline. So here we have the physical health quality of life, or the SF8 physical, with the change in the SF8 physical score on the y-axis and the interval on the x-axis from 7 days to 12 months. The sublobar section group is in orange, and the SPRT is blue. So as you can see, at 7 days, there was a significantly worse physical quality of life in the sublobar section group compared to SPRT. And that change then disappeared in all other intervals from 30 days to 12 months. And notably, both groups roughly returned to their baseline physical health quality of life by 12 months, as denoted by the minimal clinically important difference here in the dotted lines. So that's for our physical health quality of life. And then for the SF8 mental, or mental health quality of life, which is once again denoted here on the y-axis and the change from baseline, we actually see that both groups had a slightly lower than baseline mental health quality of life at 7 days. There was not a statistically significant difference between the two at that point, nor were there significant differences between the groups at any other time interval, with both roughly returning to their mental health quality of life baseline by 12 months again. Then looking at lung cancer specific quality of life with the FACT-L score, once again with its change from baseline on the y-axis, you can see that there is a significant difference in lung cancer specific quality of life at 7 days, with the sublobar section group having a much greater decline that then disappears at all other intervals from 30 days to 12 months, with there being no other significant differences between the two groups and both returning to their baseline quality of life at 12 months. So what conclusions can we draw from this? Well, first of all, this is the first study to our knowledge to compare these two cohorts in a rigorous way, looking at their quality of life over such a long period of time. And from this, we saw that sublobar resection was associated with a decline in physical and lung cancer-related quality of life at 7 days, that there was no significant decline in quality of life from baseline for the SPRT cohort in any of the metrics we looked at, and then there was no difference in the change in quality of life between these two cohorts, SPRT and sublobar resection, at any point after 7 days. So any differences that there were seemed to disappear at any other time points beyond 7 days. And very importantly, quality of life returned to baseline at 12 months in both cohorts, which you would really want to ensure when you're giving these treatments to patients on a larger scale. So our hypothesis that SPRT would have a superior quality of life did not seem to be supported, but we think that that might have been likely due to the minimally invasive nature of the sublobar resection that was done. These were patients who 90% of whom received either video-assisted thoracic or robot-assisted thoracic surgery. So quite minimally invasive relative to lobectomy or pneumonectomy. And the limitations that we could see in our study would be that the SF8 that we used may be less sensitive than other quality of life metrics, such as the European Organization for Research and Treatment of Cancer score, or EORTC. But once again, the SF8 and 36 are quite well validated in this cohort, as is the FACT-L. And there's always the potential for unmeasured confounders in spite of our attempts to adjust for them with propensity scores, especially when you're doing a prospective cohort study like this that's not directly randomized. And while we tried to look at a large interval of time, it's possible we could have missed quality of life changes that happened after 12 months. So we hope that future randomized control trials could be done to compare survival and quality of life in patients treated with SPRT compared to sublobar resection. There's actually an ongoing Valor study within the VA doing just that. There's still a few years to go before they're going to be able to present their results, to my knowledge. And then we as a group are hoping to explore further the disparities in how providers allocate different high-risk patients to the treatment modalities that they do, and what biases might be present in those allocations. So here are my acknowledgements, and I just want to give special thanks to my mentor, Dr. Juan Wisniewski, our statisticians, Grace and Kim, and my division chief, Dr. Charles Powell, without whom none of this could have happened. So thanks to all of you. My references, and take any questions.
Excellent talk, Jeremy. I think this was a very good presentation and clearly very important to also research. We have one, I think, question in the chat. Eman was asking, what are the common side effects of SBRT that might have affected patients, short-term versus long-term?
Yeah, great question. So there's a few that come to mind. So one in particular that we fear in the pulmonary community would be a pneumonitis. We've seen it with all kinds of different thoracic radiotherapy, but much more prevalent with conventional radiotherapy, which uses a much larger field and can cause inflammation over a much greater volume of lung. This is such a focused beam that's directly attacking the tumor morphology based on like pre-procedural MRIs that can perfectly kind of project the morphology of the tumor, that there's a lot less non-tumor lung affected by the radiation, and therefore a lower risk of pneumonitis. Still there though. Other things that are more common would be like fatigue, chest wall pain, especially at the site where the beam is entering the tissue. There can be shortness of breath, dyspnea, fatigue, like a lot of less specific side effects, but those would be some of the more common ones. And those, are typically more short-term, but there isn't a lot of long-term data on post-SBRT quality of life. So this was an attempt to try to kind of add to that.
Great talk, Jeremy. One question I had was, in any kind of study where you have repeated measures and especially repeated survey measures, there is always a risk of, loss to follow-up or not, or having a differential loss to follow-up in the different groups. I was wondering if you could speak a little bit to, I guess, was there any differential kind of decline in the number of people performed the surveys during the later time points between the two groups? And did you guys make any efforts to, I guess, reach out to them to see if there might be any kind of differences in the actual symptoms they might be experiencing in those people with missing data?
Yeah, great question. I think really important for any repeated survey, as you said. So we actually had quite good adherence throughout the study, between, I think it was about 86 to 88% for the first few months, and then it was around 80 to 82% in the 6 and 12-month intervals, which, given that this was a slightly sicker than average population and being collected from a bunch of different sites, we thought was pretty good adherence, and it was consistent really across intervals. We didn't have any intervals where we had like 70% or lower. But to my knowledge, we didn't extensively follow up with the patients who didn't return the calls. I think there were multiple efforts made in each instance, but we weren't often able to find out the reasons for non-adherence, which I think would be really interesting, because I imagine that a lot of those folks were probably suffering from other side effects, or could have died, or could have been readmitted. So
Right.
definitely something to consider when looking at these results.
I think
All right, awesome. And then we have one other question from Dr. Sears. She's asking, did you try to do any exploratory analyses to match lung function to your quality of life measures, or functional capacity, or any other type of physiologic metric?
We did not in this analysis, but I think it's actually a great point and one that is well taken. We did use lung function and functional capacity as covariates in our propensity scores, but we did not do direct exploratory measures looking at this. But it's definitely something to consider, and we have done a couple kind of off-spinning projects from this data set, so something that I'll definitely consider doing.
Tejas, I think you're muted.
Hi. Can you hear me now?
Oh, we can hear you now.
Yeah. I'll say, thank you, Jeremy. I think excellent talk, and we will now try and move on to our next presenter. We have Marie Karam. She is a third-year medical student in IU, and she will be presenting her research now. Marie, you can go ahead and share your screen.
Hey, thank you for that introduction. Okay. So hi, everyone. My name is Marie Karam. I'm a third-year med student. This is a project I worked on between my first and second years when I was working with Dr. Sears and Dr. Nasrallah in their lab. And so the project is entitled Decoding the Link Between XPC and Lung Cancer Susceptibility, a study of cigarette smoke-induced DNA damage in the setting of XPC deficiency. So this is what my project looked like at the conference this past May. Okay, so in the grander scheme of things, the purpose of this experiment and others done in this lab is to better understand why only about 10 to 15% of smokers will actually go on to develop lung cancer. What determines that percentage of people's risk for developing cancer, and like what is that underlying process of lung cancer tumorigenesis in those early stages? And then more recently, this protein, which is called scleroderma pigmentosum complementation group C, or XPC, has been implicated in this process of lung carcinogenesis. Classically, you might know this gene as causing the genetic disease scleroderma pigmentosum, disease of when the XPC gene is mutated in the germline. Children are born and they have this very high risk of developing non-melanoma skin cancers and melanoma skin cancers at a very young age because of severe sensitivity to sunlight, but more recently been shown to also have higher risk of developing non-dermatologic malignancies. And also people who may not necessarily have this XP disease as a germline mutation, but have polymorphisms of XPC might also have have increased risk of developing things like lung cancer, prostate cancer, pancreatic, bladder, ovarian, and hematologic cancers. And so this figure here on the left is kind of a summary of like all the different cancers it's been implicated in, as well as some of the processes that XPC's been shown to have, which I'll be talking about on the next slide. So what does XPC do and what is its importance overall? So traditionally it plays an important role in a type of DNA repair called nucleotide excision repair. This is a type of repair which detects like very bulky lesions in the DNA helix, lesions like caused by UV light, for example. And so XPC, as seen here, is really critical in detecting that damage and then kind of jump-starting the process of nucleotide excision repair. And then more recently, on the left it's been kind of hypothesized to play a role in other types of DNA processes, including the DNA damage response. This is a pathway in which DNA damage is detected, and then you see this kind of downstream signaling pathway, which will activate DNA repair, arrest the cell cycle, and initiate apoptosis and senescence if necessary. And you see here that like XPC is circled as an effector of this process, and that's certainly true, but could also play a role as like a DNA damage sensor, which can initiate or at least contribute to initiation of the DNA damage response per some more recent studies. So with all of that, we wanted to understand the relationship between XPC and chromosomal instability. And to do that, we decided to use this assay called the micronucleus assay. So a micronucleus is here denoted by the white arrow in this photo. It's a chromosome break that's been separated from the main nucleus and is now enclosed by its own nuclear membrane. So it's a reflection of genomic instability, as opposed to like what's here on the right or on the left, and it's that red arrow pointing to a nuclear bleb, and that's just a protrusion attached to the nucleus. It's not a true micronucleus, but together in this presentation, at least, we refer to combination of both micronuclei and nuclear blebs as being nuclear aberrancies. So by looking at the number of micronuclei forming, we wanted to get an idea of chromosomal and genomic instability as a whole, and we hypothesized that combining cigarette smoke and then XPC knockdown would cause genomic instability, which would activate the DNA damage response and increase the frequency of micronuclei as well as nuclear aberrancies. So to do this, we use 3 cell lines, BEAS2B, which is a bronchial epithelial non-cancer cell line. And then we use 2 lung adenocarcinoma cell lines, H1299 and A549 cells. All the cells were transduced with either an shRNA that is like an SH control RNA or an SHXPC RNA in order to knock down XPC. And then cells were exposed to either increasing concentrations of cigarette smoke extract or air control, and then underwent this cytokinesis block micronucleus assay or protein extraction and immunoblotting for the DDR proteins. So for that cytokinesis block micronucleus assay, the process involves this molecule called cytochalasin, and it's a cytokinesis blocker. So cytokinesis is that stage of mitosis where the DNA is like enclosed by a nuclear membrane, and it's a discrete entity which you can visualize micronuclei. So this is why we block it at cytokinesis and then fixate the cells and then look at the frequency of micronucleus formation. So with that, the results we got with regards to the micronucleus assay, here we have the BEAS2B, the results of just one of the 3 cell lines, the BEAS2B cell lines. So we found that micronuclei and nuclear aberrancies increased significantly with cigarette smoke exposure, and these were statistically significant effects in C and D. But then we also found that XPC knockdown also increased in the frequency of micronucleus formation in BEAS2B cells, and this was a significant effect as well. But cigarette smoke extract and XPC knockdown were 2 independent variables that were not synergistic in their effect, but each significant in its own ability to increase frequency of micronuclei. So here it was, this is the slide that shows the H1299 cells, and this is one of the 2 lung adenocarcinoma cells. BEAS2B is the non-adenocarcinoma cell line. So here, micronuclei increased with cigarette smoke exposure. Nuclear aberrancies as a whole increased with cigarette smoke exposure, but XPC knockdown did not have that same effect of increasing the frequency of micronuclei in this lung adenocarcinoma cell line. But then also in this one, this is the results of our A549 cell line. This is the second adenocarcinoma cell line. And again, XPC did not have an effect on increasing the frequency of micronucleus formation. Nuclear aberrancies did increase with cigarette smoke exposure. Micronuclei did not. So to summarize just at least the results of the cytokinesis assay, we found that for the most part, cigarette smoke increases the formation of micronuclei and nuclear aberrancies, but XPC knockdown only had a significant effect in the bronchial non-adenocarcinoma cell line, the BEAS2B cells, but the 2 adenocarcinoma cell lines were not affected in that same way when XPC was knocked down. And then this is the slide for our DDR activation. So we did immunoblotting for 3 proteins involved in the DNA damage response, ATM, DNA PKCS, and CHEK2. And we used the phosphorylated versions of these proteins so that we could look at like specifically DDR activation. And we found that in BEAS2B, which is here in that top left corner, and then H1299 in the top right corner. So again, you can see that cigarette smoke really has a significant effect on increasing that frequency of activation of the DDR. So you see that increased intensity as you go across. But then you can also see that XPC knockdown amplified that effect as well when you compare SH control to XPC in both of those top 2 columns. But then in the bottom right, this is our A549 sample, and cigarette smoke had that effect, but we didn't have that effect with XPC knockdown. So for the most part, SH control and SHXBC were the same in A549 cells. And so these are results we're still working on, like clarifying. We want a better, we want to repeat these. And we did have some issues with like the A549 immunoblotting. We're having some difficulty obtaining good blots, which we previously didn't have this problem in the past in our lab. So this is something that we want to troubleshoot more and repeat to have more clarity on why we got these specific results. But one possible reason is that H1299s are p53 null, and p53 is actually an integral part of the DDR pathway. So whether there's like a difference in the underlying baseline dynamics between the A549s and H1299s just because of the fact that H1299 cells are p53 null, that's a possibility. So for the conclusion, so we drew a couple of conclusions from all of this. First being that cigarette smoke exposure and XBC knockdown were able to contribute to the formation of these large-scale chromosome breaks manifesting as micronuclei. So cigarette smoke exposure, is a known mutagen, and XBC knockdown has been shown to cause DNA damage in the past, but specifically in this type of DNA damage being these chromosome breaks as micronuclei. This is kind of what our research was able to show. We also conclude that, we conclude that cancer cells may be able to rely on alternative methods of DNA repair pathways bypassing XBC, just based on the fact that both of the lung adenocarcinoma cell lines did not get affected by XBC knockdown in terms of like the micronucleus frequency. Could it be that they use some kind of alternative DNA repair pathway since they may not be as reliant as XBC? This is also a possibility. Another thing is that XBC may play a role in the DNA damage response. This is kind of a broad conclusion because we still want to clarify this more. And it's a little complicated because XBC has a lot of different roles. And part of that is probably one of our project limitations, but additionally, XBC likely is a key player in some of the early stages of lung tumorigenesis. So if you look in this figure here below, we hypothesize that if you combine XBC polymorphisms with aging and random mutagenesis with cigarette smoke and mutagen exposure, you might get this early loss of XBC. And this contributes to genomic instability. And then if you add that with continued cigarette smoke exposure, you might get additional mutations in tumor suppressors and proto-oncogenes, which then could drive tumorigenesis. So this is our working hypothesis at the moment. And so there are project limitations. With any project, there are limitations. And for this project specifically, there is, of course, human bias associated with just counting micronuclei. We try to offset this by having a large number of cells with each sample and then repeating it multiple times. But this remains a limitation nonetheless. And again, like I've mentioned a little before, XBC has a lot of diverse functions, and it makes it difficult to pinpoint the mechanisms for our results. Because XBC plays that really important role in nucleotide excision repair, but might play a role in other types of DNA repair processes, including base excision repair, non-homologous end joining, and like I mentioned before, it might also serve as like a global DNA damage sensor, which could help activate the DNA damage response. So with all of these components, it's a little difficult to pinpoint that specific mechanism, which is kind of what brings me to my next point, which is future directions and what we want to do next to further clarify that. So one option is possibly like treating cells with other types of DNA repair inhibitors. For example, like a Ku inhibitor, Ku is a very important component of a type of DNA repair called non-homologous end joining. So if we could inhibit a specific type of DNA repair, or actually just introduce specific types of carcinogens found in cancer, which we know create very specific types of DNA damage, because, tobacco has lots of different carcinogens, and each carcinogen can cause different type of damage. Maybe this could shed some light on the underlying mechanisms and provide us with some clarity there. Another thing we would like to do is investigate micronucleus formation and verify results in translational samples, maybe primary cells, and then continue the DDR experiments and clarify the effect that XBC knockdown has on DDR activation. So thank you. These are my references and acknowledgements. Any questions?
Wow, what a tour de force, Marie. A tremendous amount of work and really fantastic presentation.
Thank you.
So I guess honestly, most of the questions I had, you kind of already addressed in a lot of your future directions. But I'm going to come back to, one of your many interesting findings, which is, that you found that the XPC knockdown did not increase micronucleus frequency in the two adenocarcinoma cell lines. And I know that you're postulating that there's obviously some alternate DNA repair mechanisms that might be, kind of underlying some of those findings, and that those, comprise some of your future directions. But I guess I was just wondering if you could hypothesize for us, what some of those other DNA repair mechanisms might be, and also if you could comment on whether or not, this finding of yours was kind of expected or unexpected.
Yeah, it was, I think, unexpected. I don't know that we had like a specific expectation. I think we did expect actually that like XPC knockdown could possibly augment that formation of micronuclei even in cancer cells, but that it specifically would affect like the bronchial epithelial cell line and not the adenocarcinoma cell lines. I don't know that we were specifically anticipating that difference between the three cell lines. As for what alternative methods of DNA repair they could use, there's a lot of research out there. There's some articles that, like, for example, suggest that there are like less, for example, cancer cells might rely on like lower integrity pathways of DNA repair, maybe things like non-homologous end joining or others that we don't have a good, clear idea of at this point. Whereas, a non-cancer cell line might rely on like higher integrity methods of DNA repair, something that actually relies on XPC and all the other things we've mentioned before. So I don't know if that truly answers your question, but I don't know if Dr. Sears has any better ideas, but yeah.
Why don't you answer? This is your presentation.
I had a quick question, and again, it might be a really basic one, but I saw you, selected adenocarcinoma cell lines. But is there a specific reason you chose that as compared to, say, squamous cell? Given we know that there is a higher, smoking risk and squamous cell sort of match.
I don't know that there was a specific reason for that. I know we wanted to do eventually more, we wanted to add more cell lines. And I think at one point we actually were planning on doing like squamous cell and I think other adenocarcinoma cell lines. I think it was mostly a time restriction thing where it was limited to like those three.
Oh, pretty interesting. I think this is quite fascinating.
Thank you.
Amazing presentation again. And we have one more question from Eman. She says she learned a lot about XPC, and she was just curious if there are any currently available targeted therapies against XPC right now.
That's a good question. I don't think there are, not to my knowledge, at least.
Fantastic. Well, we are perfectly right on time. And unless anyone else has any other questions, I'm happy to introduce our final speaker of the afternoon, Eman Metwally, who is at UNC and I know is in the midst of writing her first big grant. So thanks for taking the time to join us today, Eman. Eman, take it away.
Yeah, thank you, Roger. Can you see my screen?
Yes.
Yep, we can see it. And yep, it's perfect.
Okay. So yeah, this is a research that is actually an ongoing research that I have been doing during my postdoctoral research fellowship at UNC, the epidemiology department, and it's about emergency diagnosis of lung cancer among patients with chronic obstructive pulmonary disease or COPD. I have no conflict to disclose. And yeah, as I mentioned, the results that I'm going to show is not published yet. I'll start by just an overview about how we defined emergency diagnosis of lung cancer, the gap that we tried to address, the methods we used, the results, and how we interpreted them. So as you know, COPD is a common comorbidity, and among patients with lung cancer, the estimated prevalence in the US is between 50 to 70%. It's an independent risk factor for lung cancer and a competing cause of death based on severity. The way we defined emergency diagnosis of lung cancer in the study is that lung cancer diagnosis that occurred during acute inpatient hospitalization after emergency department visit. However, this is not the only definition for emergency diagnosis of lung cancer. Many studies, especially here in the US, do not require this acute inpatient hospitalization part. So, for example, they would define emergency diagnosis of lung cancer as any lung cancer diagnosis that occurred within, for example, 30 days of emergency department visit, or maybe a longer interval, like 60 days with an emergency department visit. The reason we choose this acute inpatient hospitalization criteria is to be more like conservative in how we define emergency diagnosis, and to align with maybe more previous studies that occurred, especially in Europe and in UK. Emergency diagnosis of lung cancer has been associated with disadvantaged patient characteristics, such as older age, racial minority, low socioeconomic status, multi-morbidity, and frailty. Because of this poor patient characteristics, emergency diagnosis is also associated with poor cancer outcome, such as late-stage diagnosis, under-receive of cancer treatment, and poorer survival. So the gap that we tried to address is that we wanted to examine the association between COPD as a common comorbidity among patients with lung cancer with this kind of maybe poor prognostic way of diagnosing lung cancer. And given that both lung cancer and COPD are associated with racial and socioeconomic disparities, we wanted also to examine this association across population group of different race and socioeconomic status. These are the specific questions we tried to answer in this study regarding the prevalence and the clinical characteristics, and also the association between COPD and emergency diagnosis of lung cancer. We used the surveillance epidemiology and end result, SEER, linked to Medicare database for patients diagnosed with incident lung cancer between 2008 and 2017. We selected this SEER Medicare database because it is representative of 40% of US population diagnosed with cancer, older than 65 years. The exposure in this study is comorbid COPD, defined in Medicare claims by looking backward from the diagnosis of lung cancer to 365 days before and 30 days after lung cancer diagnosis, and the outcome with emergency diagnosis of lung cancer, as I defined earlier. We also examined common socio-demographic characteristics, clinical characteristics such as healthcare utilization due to any reason before lung cancer diagnosis, tumor characteristics, and surgical receipt of lung cancer treatment as the first line of treatment. So the baseline study population was over 185,000 patients. Among them, like more than 70% of them had comorbid COPD. And the emergency diagnosis of lung cancer among patients with COPD was more than patients without COPD. Then when we looked into the prevalence of acute exacerbation, we observed that acute exacerbation of COPD is more common among patients with ED lung cancer compared to those without emergency diagnosis of lung cancer. This is kind of a summary of the descriptive analysis of our study. So the mean age of diagnosis for lung cancer was 76 years. Based on SEER registry socio-demographic characteristics, 84% were non-Hispanic white. There were equal distribution of socioeconomic status based on Yost et al. Algorithm. 16% of our patients with lung cancer had frailty based on KIM score, and 23% or quarter of our study population had 3 or more comorbid conditions, including COPD. No surprises in non-small to small cell lung cancer distribution. Early stage was detected in 21% of patients with lung cancer, and surgical treatment was received in 19% of our study population. when we stratified our analysis by COPD, we observed that patients with comorbid COPD and lung cancer were more likely to be non-Hispanic white, to have low socioeconomic status based on Yost et al. And this is an area-level socioeconomic measure that's based on education, income, poverty level, neighborhood, socioeconomic status. And then we also evaluated, as I mentioned, frailty based on, this is like a predicted probability of frailty based on Medicare claims that is associated with assisted living. And then we evaluated comorbidity burden based on the Charlson Comorbidity Score Index. Patients with COPD were more likely to have small cell lung cancer compared to those without COPD, more likely to get diagnosed at an early stage lung cancer, and more or less similar receipt of surgical treatment as their first line of lung cancer treatment. This is kind of how we try to stratify our analysis again, but this time by the outcome, by emergency diagnosis of lung cancer. And we observed that similar to previous studies, emergency diagnosis of lung cancer is more common among racial minorities and those with low socioeconomic status. Patients with emergency diagnosis of lung cancer were more likely to get acute exacerbation of COPD and to have more comorbidity burden and more frailty. When it comes to lung cancer outcomes, those with emergency diagnosis of lung cancer were more likely to have small cell lung cancer diagnosis, to be more likely to get diagnosed at late stage, like big difference as you see here, and much less likely actually to receive surgical treatment as their first line of lung cancer treatment. Here is the results of our association analysis. First, we tried to examine the association between COPD and emergency diagnosis, and we observed that COPD is associated with 28% increased prevalence of emergency diagnosis of lung cancer, comparing patient with versus without COPD. And this is in adjusted models. And then we subcategorized our study population into only those with comorbid COPD and lung cancer, and we examined the association between acute exacerbation of COPD and emergency diagnosis of lung cancer. And we observed actually very high, increased risk of prevalence, like 76% increased prevalence of emergency diagnosis among those with acute exacerbation versus those who did not have acute exacerbation of COPD during the year before lung cancer diagnosis. This first plot is showing how we try to examine the association between acute exacerbation, which is the strongest association we found, with emergency diagnosis of lung cancer across population groups based on their race and socioeconomic status. And to our surprise, actually, we found that non-Hispanic white and those with higher socioeconomic status had stronger association. We did not have maybe good explanation for that, except that maybe those groups that are considered maybe more advantaged here in the US might have maybe better access to healthcare that enabled the healthcare system to detect their acute exacerbation of COPD diagnosis. And maybe I have to back up here. The way we defined acute exacerbation of COPD is based on claims data. Many patients with acute exacerbation of COPD might not seek medical advice and might not be detected accordingly in the healthcare system and the Medicare claims. So a lot of layers come into this conclusion, and maybe any problem in any of these rail, like access to healthcare, for example, might explain this unexpected results for the association between acute exacerbation and emergency diagnosis. And based on that, we concluded that emergency diagnosis of lung cancer is a common route for diagnosis of lung cancer in the US. Approximately 25% in our study population were diagnosed using this route, the emergency diagnosis. COPD and acute exacerbation of COPD, both of them increase the risk of emergency diagnosis and its poor cancer outcomes, including late-stage diagnosis and less receipt of surgical treatment. This is an observational study, and we can't draw any causal inference, but our results show that acute exacerbation might be an important risk factor that can be incorporated into screening protocol for early detection of lung cancer. This is the team that I'm working with. My primary mentor is Dr. Caroline Thompson, and I have my gratitude to my other mentors in the epidemiology department, Dr. Jenny Land, Charles Poole, and Sharon Paycock. In the School of Medicine, Michael Bradley Drummond. Yep, these are my funding, and thank you. Please let me know if you have any questions.
Thank you, Eman. I think that was an excellent talk. And now I'm clearly thinking about all the acute exacerbations that, I saw during like residency and fellowships. I'm like, it's fine, it's fine. But then I had one particular question. So clearly you're saying that, using acute exacerbation of COPD could be part of, I guess, some screening, right? But there is a major chunk, and I'm assuming you got all of this through the Sears database, but does the database capture, somebody that has COPD that, just goes to an urgent care and says, hey, give me some steroids and antibiotics, and, sort of get missed and they're not followed up in an actual, I guess, healthcare system? Does the database capture that, or are we missing all of those people in the work that you've done?
Yeah, so that's an excellent question. Thank you. The way that we defined acute exacerbation is based on COPD diagnosis that is associated with maybe acute inpatient hospitalization, or COPD diagnosis that is associated with emergency department visit. The way that COPD and acute exacerbation of COPD is defined in SEER Medicare, it's based mainly on healthcare utilization that is recorded in Medicare claims, and this can include any patient encounter at inpatient or outpatient or emergency department visits. So we used validated algorithm, one or more ICD claims, ICD-9 or ICD-10 codes that is used to define COPD. And similar to them, some codes are used to identify acute exacerbation of COPD. And we added, to add more accuracy, we also added some ICD codes for acute respiratory failure in order to differentiate between COPD and acute exacerbation of COPD. But all of these are validated algorithm published in the literature to identify COPD and acute exacerbation of COPD in Medicare claims. And back to your question, yes, as I mentioned, it's very possible that we are missing many patients with acute exacerbation because they did not maybe fall under the criteria that used in previous algorithm, or they did not even seek medical advice because they don't have access, they don't have insurance.
Would that reduce your association with, I guess, emergency? If we had captured all of that, would that reduce your association with the emergency diagnosis of lung cancer?
It might, yes, it might attenuate our association, because if we have larger number of patients, that means we might have stronger association. So it might attenuate our association. And currently, we are working to refine these analysis. We are working to define acute exacerbation by frequency. So we are going to look into acute exacerbation that occurred maybe 2 or 3 times during the year before lung cancer diagnosis, and the exacerbator phenotype, and differentiate and make them another category than patients who only maybe had 1 acute exacerbation of COPD.
Yeah, that would be awesome to know.
Yeah, thank you for the question.
Yeah, Eman, great talk. Kind of along the same lines, I know you mentioned that, your kind of framework of in which you asked the question for the study was not necessarily a causative pathway that you're looking at, more of just looking at association. But I guess I just wonder out loud, from a practical perspective, I'm just thinking in my own practice, the only times that I would really recommend making, a lung cancer diagnosis while someone is, admitted to the hospital would really be, number one, to start treatment, which is, I'm not surprised that you found that there was a higher proportion of people with small cell, for example, which obviously responds very quickly to chemotherapy. Or alternatively, if you thought that there were significant concerns for the patient's inability to follow up, as an outpatient to get diagnosed and ultimately get treatment. So I guess long-winded way of asking my question, which is, do you have data in your data set of what proportion of individuals who were diagnosed, as an emergency diagnosis of lung cancer received treatment during that index same hospitalization?
I have data, but I don't have I did not look into that yet. Part of my ongoing research, maybe in a few months from now, is that I'm going to look into treatment received, all treatment, either chemotherapy, radiotherapy, or surgical treatment. But coming to your question, it's also this is part of the data limitation. The date of diagnosis of lung cancer that is associated with acute inpatient hospitalization can vary based on how the registry recorded it. Some of the diagnosis is based on clinical staging without maybe biopsy or something like that, and some of the diagnosis recorded is based on pathological diagnosis. So this variation in the time of recording of the lung cancer diagnosis can make a lot of differences between how we examine these associations. How I think about application of our finding is that maybe a patient who's coming to the emergency department with symptoms of acute exacerbation, and they are just given the treatment of acute exacerbation or maybe escalating the treatment of COPD, maybe physicians should think about the possibility of lung cancer in these patients, especially if they have other risk factors. It is not only acute exacerbation. This might be the symptoms of lung cancer. And this is one of the comments that I heard on the poster in the ATS, is that some of the researchers told me, who told you that this acute exacerbation is not flaring of lung cancer?
Yeah. Another thing to think about would be, if you had, I think Tejas was kind of getting at this as well, as far as, documentation of healthcare encounters or healthcare engagement, as a baseline variable, maybe I think you mentioned 12 months beforehand, you had data, before lung cancer diagnoses were made, just to get a sense of, each individual's, kind of how frequently they're following up with, say, their pulmonologist or something as an outpatient. And I almost wonder out loud if, some of this might be explained by, if I had someone with a really poorly controlled COPD who I'm now recommending to get let's say a bronchoscopy to diagnose lung cancer, they might end up getting admitted because they, are not able to go home after their initial, outpatient bronchoscopy procedure. So just another thing to think about as far as, is it the chicken or the egg kind of situation? It's a little bit challenging, I think, for this type of outcome. But either way, extremely interesting work, and thank you for sharing it with us. So we are at the end of the hour, and I just wanted to thank all three of our abstract winners for taking the time to present their work again, a couple months after they initially did at ATS 2024. And I know I certainly learned a lot from all of you, and I'm really, really pleased that you're able to share your work with the greater ATS community. And as a reminder, all of these webinars are recorded and will be posted to our Thoracic Oncology Assembly website in a few weeks. And also a quick plug, we are hosting another webinar. We're doing 3 webinars this month on lung cancer screening for individuals who have never smoked. And that'll be on Monday, September 30th at 2 p.m. Standard Eastern Time. So hopefully some of you can join us for that as well. And with that, we'll wrap up our webinar. And thank you so much for everyone for attending. And thank you to our presenters for presenting.
Thank you all.
You all.
Thank you.